A very good morning to Dr. Anshika Dengre, and I will be presenting this CGR on behalf of the Dept of Anesthesia on the pet experience since the beginning of Pediatric Anesthesia Fellowship Program. Over the last 6 months, we've managed 1,200 pediatric patients. Of these, 540 cases were conducted under non-operating room anesthesia, which is nephrology, endoscopy, and radiotherapy. 61 emergency cases and 367 elective cases in surgery. 102 pediatric urology cases being done in the main OT complex, 85 cases in plastic surgery, 46 pediatric patients underwent robotic surgery, pediatric urology, and pediatric surgery. 1/3 of our patients were below the age of birth. The type of cases that were managed in the operating room were predominantly under pediatric surgery and pediatric urology and included open and laparoscopic abdominal surgical procedures, cystoscopic procedures, surgeries of the head, neck, and airway, and spinal anomalies like meningomyelocele. We have an ICU on the first floor of PMSSY, and I will now be discussing our ICU trends and outcomes. Since June, we've admitted a total of 482 pediatric patients. Of these, 469 were transferred in from the OT for post-operative care, and 30 have been transferred in from the ward. This chart summarizes the age profile of our ICU patients. Most of our ICU admissions of less than 4 hours, 37, which were largely post-operative. Around 28% of the admitted patients required overnight ICU stay. Indications for overnight stay predominantly included post-operative monitoring and care, need for oxygen support, or requirement for invasive or non-invasive ventilation along with vasopressor support. We would now like to share some insights from behind the scenes, aspects of perioperative care that often go unnoticed but are crucial in keeping our pediatric surgical patients safe. This is the case of a neonate with a giant omphalocele. Usually, the general dictum in large omphaloceles is a two-staged repair to avoid post-operative respiratory complications and abdominal compartment syndrome. But with physiological monitoring and non-invasive ventilatory strategies, we could achieve this repair in a single stage. We wish to share that experience through this case. This was a 7-day-old baby with a defect size measuring 6 into 5 centimeters, containing solid viscera such as the liver and spleen. He was a term baby referred to SGPGIMS for omphalocele repair and posted for the same on day 7 of life. As previously mentioned, the defect size was 6 into 5 centimeters, which was a large defect. Omphaloceles are midline abdominal wall defects containing herniated viscera covered by a membrane. Incidence is 1.24 per 10,000 live births. Out of this, only 37% have solid viscera. These children are at high risk due to pulmonary hypoplasia and small abdominal cavity causing abdominal compartment syndrome. Literature-wise, when we reduce these large omphalocele, it results in raised abdominal rise can cause abdominal compartment leading to bowel ischemia. Is also a concern due to the large exposed sac. The understanding and prevent abdominal compartment syndrome. When reducing omphalocele, intraoperative monitor parameters such as peak airway pressures can warn regarding impending abdominal compartment syndrome. Decreased urine output, hypotension, or desaturation are warning signs and dictate us to stop reducing any further. I would now like to narrate the way we manage this large omphalocele in a single-stage repair. To begin with, the child was intubated and ventilated with a baseline peak inspiratory pressure of 18. An orogastric tube was inserted for continuous decompression. Gradual reduction of contents was done with constant communication along with monitoring and sharing of peak airway pressure trends in real time as reduction advanced. It was planned to stop reduction when peak inspiratory pressures rose significantly. But this was not so in our case. The peak inspiratory pressures rose to 22 after complete closure, which was acceptable. Stable ECO2, oxygenation, and hemodynamics ensured the baby being extubated on the table post-surgery. Parameters monitored post-operatively included abdominal girth, lactate levels, and urine output, which remained within range. Derangement in the above would have helped in early recognition of rising intra-abdominal pressures or poor perfusion. There was no evidence of abdominal compartment syndrome post-operatively. This child was extubated on table but needed nasal CPAP post-operatively. This was due to limited thoracic expansion and basal atelectasis from the defect, which was already a post-operative concern for us. Nasal CPAP and permissive hypercapnia kept the alveoli recruited, provided gentle distending pressure without stressing suture lines, allowed spontaneous breathing while maintaining oxygen, and reduced the work of breathing and need for was safely achieved in spite of a giant omphalocele. Physiology-guided decision-making proved more reliable than defect size alone. Close post-operative monitoring and multidisciplinary coordination between the anesthesiologist and pediatric surgeon enabled early detection of respiratory or abdominal compartment concerns. Thus, a favorable outcome was achieved in spite of initial apprehension. That is, the child had a stable respiratory course, uniform lactates throughout, was weaned to room air, and discharged to ward. I will now be discussing our case 2. This is a case where the child had multiple congenital anomalies and was operated quite a number of times. We had an emergence crisis which was tackled with the help of laryngeal ultrasonography. Let me start with a short background summary. He was a 3-year-old child with repaired tracheoesophageal fistula, persistent gastroesophageal reflux disease, and multiple musculoskeletal deformities. He was a 34-week preterm infant presenting with high anorectal malformation, type C tracheoesophageal fistula, mater, subaortic ventricular, torticollis, scoliosis, and microtia with sensory neural hearing loss. He was admitted to SGPGI with respiratory distress following surgical correction of the tracheoesophageal fistula and anorectal malformation. He was then managed in the NICU on nasal CPAP, experiencing a few episodes of desaturation due to regurgitation of feces. Hence, he was investigated for the same, and severe persistent gastroesophageal reflux disease was documented. For this, the mother was advised to nurse the infant in a propped up posture. Kinetic agents, the infant still experienced multiple episodes of respiratory distress due to regurgitation of feces. He was then managed in the NICU on nasal CPAP, experiencing a few episodes of desaturation due to regurgitation of feces. Hence, he was investigated for the same, and severe persistent gastroesophageal reflux disease was documented. For this, the mother was advised to nurse the infant in a propped up posture. He underwent posterior sagittal anorectoplasty and surgery to maintain continuity of bowel as a final correction of his congenital anorectal malformation at our hospital. Both these 2 to 3 hour surgeries went uneventful. As a sequelae of TEF repair, he had an esophageal stricture for which esophageal dilatation was done at the age of 2 years. Now, he came at 3 years of age for the present case of urethroplasty. So, during pre-op evaluation, the child was considered high risk for perioperative respiratory complications due to severe gastroesophageal reflux disease, recurrent aspiration pneumonia and respiratory distress, and an increased risk of hyperreactive airway after TEF repair. We also anticipated a difficult airway in view of left facial asymmetry, torticollis, short neck, and existing scoliosis. This child had a specially designed chair that he had been using to even sleep in due to his inability to lie supine. So, on the day of surgery, the child was pre-medicated for separation anxiety, nebulized in view of his hyperreactive airway, and wheeled in the operating room on a propped up ICU bed, taking care of his gastroesophageal reflux disease. After induction with fentanyl, propofol, and rocuronium, 3 attempts of laryngoscopy were done, which failed viewing of vocal cords. As per the difficult airway algorithm, our next step is to secure the airway with a supraglottic airway device. This is not normally used in gastroesophageal reflux disease, but now newer generations of supraglottic airway devices have improved seals and separate gastric ports, facilitating suction and aspiration. Due to airway manipulation, in spite of preoperative nebulization, the patient had bilateral wheeze, which was managed with intravenous hydrocortisone and salbutamol puffs. Gradual improvement in ventilation was observed. Once improved, we continued with the surgery. 3 hours of surgery went uneventful. The child was re-nebulized, reversed if muscle relaxant, watched for adequate effort, after which we removed the supraglottic airway device. But after removal, the child developed chest retractions, there was decreased air entry and desaturation, and we were unable to mask ventilate the child, which was previously possible. So the LMA was reinserted. But this time, we were unable to ventilate even via the LMA. So we did a video laryngoscopy, which revealed significant glottic edema. A small-sized endotracheal tube placement was managed with great difficulty, and we were finally able to ventilate the patient. Due to inadequate ventilation, he had retained CO2 and had severe respiratory acidosis. We then nebulized the child with adrenaline and levosalbutamol for glottic edema and his existing hyperreactive airway and performed a laryngeal ultrasound. Now, last time, due to the glottic edema, and were able to intubate with great difficulty. So this time, we were wiser and did an airway ultrasound. Laryngeal ultrasonography is a useful non-invasive tool for the evaluation of vocal cords and laryngeal morphology in intubated patients. So after nebulization with adrenaline, we did the ultrasound. It showed resolution of cord edema, so we extubated the patient. The child had no post-extubation stridor and was shifted to the post-op on nasal prongs in a seated position. He was kept in the post-op for observation, but 2 hours later, he again developed chest retractions and stridor. These subsided on nebulization with adrenaline. He required supplemental oxygen via nasal prongs for around 40 hours and was observed on room air for another 8 hours prior to shifting to the ward. Thus, the air column width measured by ultrasound may potentially identify patients at risk for post-extubation stridor, in whom caution should be exercised after cuff deflation and extubation. I will now be discussing our third case. Our institute is a referral center for tracheoesophageal fistula, and we wish to highlight a problem in children after TEF repair who are coming for subsequent anesthetic and surgical interventions requiring endotracheal intubation, like in this case. This was a 2-year-old child posted for left open radical nephrectomy. He had a type C tracheoesophageal fistula, which is the commonest type. At 1.5 years of life, he visited the hospital with complaints of abdominal pain and distension. He was diagnosed with a kidney mass and posted for resection of the same. In all post-TEF repair cases, we evaluate for history of noisy breathing, recurrent respiratory tract infections, wheezing, cough, or gastroesophageal reflux. Presence of any of these hints at persisting long-term post-TEF repair complications or even a persisting tracheoesophageal fistula. This child was playful with no such history. General physical examination and systemic examination were normal, and blood investigations were also normal range. To add to our clinical interpretation, the CT chest also showed no evidence of esophageal stenosis, outpouching, or a persistent tracheoesophageal fistula. So, we went ahead with the surgery, and on the day of surgery, the child was pre-medicated for separation anxiety, induced, bag and mask ventilation was easy, laryngoscopy was performed, the entire glottic opening was visible, and the child was intubated. But on auscultation of lung fields, to our distress, there was no air entry, no chest rise was observed, and no EtCO2 was shown on the monitor. We were unable to ventilate the child. So we checked the circuit, ruled out kinking of the tube, rechecked the position of the endotracheal tube, suctioned the tube for secretions, gave salbutamol puffs suspecting bronchospasm, but was still unable to ventilate the patients. During these attempts at troubleshooting, the child's saturation started to fall. Incidentally, neck extension during repeat laryngoscopy showed improved ventilation. Saturation was now 100%. So while maintaining neck extension, fiber optic bronchoscopy was performed and diverticula was visualized. The tip of the endotracheal tube was sitting right on the diverticula. This had not been reported on CT, and the child had no previous respiratory complaints suggestive of the same. The endotracheal tube was then maneuvered under fiber optic guidance, trying to avoid the diverticula. This is the video on fiber optic bronchoscopy. We are just above the carina. At 3 o'clock, we are able to see the diverticula, and we were able to intubate the trachea under fiber optic guidance into the true lumen of the trachea just above the diverticula. The patient then underwent an uneventful intraoperative and postoperative course and was discharged on post-op day 7. This case prompts us to think, should we perform routine bronchoscopy in all children post-TEF repair when we are intubating them? We tried to find the answer to the same through literature. Children with tracheoesophageal fistula often experience significant aerodigestive complications following repair, such as chronic cough, choking with feed, gastroesophageal reflux disease, asthma, allergic rhinitis, and recurrent respiratory infections. An acquired tracheal diverticulum consists of esophageal tissue that remains adhered to the trachea following surgical repair of esophageal atresia or tracheoesophageal fistula. As high as 33% incidence is reported post-TEF repair. Our patient was unique in the sense he did not have any symptoms. Since a very small percentage is asymptomatic, preoperative bronchoscopy is not routinely performed in post-TEF repair patients with no aerodigestive symptoms. In such cases, mask ventilation and endotracheal intubation is performed with ease. But as the diverticulum can provide a false tract, there is misplacement of the endotracheal tube into the diverticulum, causing difficulty in ventilation. The wall of the diverticulum is weaker than normal, so there is risk of diverticulum perforation after positive pressure ventilation, leading to mediastinal or subcutaneous emphysema. This has already been reported in existing literature. Tracheal diverticula are generally diagnosed via CT, but it could have been missed due to the dynamic collapse of the diverticulum during quiet breathing and pressure-dependent expansion during mechanical ventilation. Thus, in our case, it was diagnosed on bronchoscopy. We need to be wary of tracheal diverticula as a potential complication post-TEF repair whenever we face any difficulty in ventilation after intubation. Therefore, we propose the primary method of securing airway to include fiber optic guidance whenever possible. I will now be discussing our fourth case, where we describe a novel approach to anesthetic management in a preterm infant posted for open herniatomy. This was a 14-week-old baby at 44 weeks post-conceptional age, posted for right open herniatomy. He was, like previously discussed, he was a preterm baby admitted in the NICU in view of respiratory distress and prematurity and referred to SGPGI on day 4 of life. He was discharged after 37 weeks post-conceptional age and posted for the herniatomy at 44 weeks post-conceptional age. So what made our preterm special? Immature respiratory centers put preterm neonates at an increased risk of apnea, the incidence of which is inversely related to post-conceptional age. Reduced residual capacity and a compliant chest wall leads to rapid desaturation during airway manipulation in this age group. Moreover, anesthetic implications of congenital cardiac anomalies make general anesthesia more challenging. Our preterm had an atrial septal defect. So, there is always a dilemma of choosing appropriate techniques of general anesthesia versus regional anesthesia in preterm neonates. Since general anesthesia is associated with increased risk of respiratory complications and delayed recovery, but spinal anesthesia alone has limited duration of action due to high CSF turnover rate, a high failure rate, and may not cover long procedures. The effect of spinal anesthesia in neonates lasts only about 30 to 60 minutes. So while trying to balance the two, we came upon a novel approach to address this issue, that is combine caudal plus spinal in a single puncture. Caudal anesthesia is very similar to our epidural block. Here, the drug is injected via the sacral hiatus in the caudal space, which is more or less post-operative analgesia as well as increasing the duration of the spinal block. This is the point of needle entry. As you can see here, this is the point of needle entry, and this is the caudal space, and the highlighted green portion is the dural sac. But this technique is challenging, but made possible with the use of ultrasound, which shows real-time needle advancement, drug administration, and increases accuracy. Now, Traditionally, we all know that support is given at the lumbar level. However, it is difficult to perform in real time using ultrasound. When we use the technique shown in the image, the ultrasound probe is placed at the sacral hiatus, so both the thecal sac caudal space can be accessed in the same prick. So on the day of surgery, the infant was sedated, placed in the lateral decubitus position. All aseptic precautions were maintained, and the dural sac and caudal space visualized by ultrasound by keeping the probe here. The needle was then inserted from this point into the dural sac, as you can see. Drug injected into the thecal sac, post which the needle was withdrawn, inserted into the caudal space where further drug was injected. After this technique, 120 minutes of the surgery was successfully completed under this combined spinal caudal block. The child was kept under observation overnight and shifted to the next. Spinal anesthesia has previously been performed in neonates for inguinal surgeries with an approximately photography, and entering the thecal sac via the caudal space may increase success rate. To conclude, regional anesthesia avoids air manipulation, minimizes general anesthesia exposure, and maintains spontaneous respiration. Ultrasound guidance increase accuracy, safety, and success rate, making regional anesthesia via this technique a viable alternative to general anesthesia in a term. We have recently used this technique to administer anesthesia to another preterm at 47 weeks post-conception age. That is, we gave both spinal and caudal by the same route. There was complete blockade lasting the surgical duration of 90 minutes. So robotic assisted thoracoscopic surgeries have recently been started at SGPGI, and we are one of the few centers conducting them. They are always a challenge in pediatric patients due to limited gadgetry available for lung ventilation. Assisted thoracoscopy is possible in small children. While in adults, we have many gadgets to achieve lung separation, like double lumen tubes, univent tubes, or bronchial blockers. In pediatric population, due to the anatomy and the size of the tube, a double lumen tube, or use other advanced gadgets. The blocker available commercially is 5 French. It is always inserted via bronchoscopy. Since the smallest size of the bronchoscope is 2.8 mm, this assembly can be utilized only in children with at least a 5.5 mm internal diameter endotracheal tube. So this is the experience of 4 cases, out of which I will be describing 2. So this was a 3.5-year-old child with bronchopulmonary sequestration posted for lobectomy via robotic assisted thoracoscopic surgery, which we were able to achieve one lung ventilation by placing a bronchial blocker in a modified way. This was a term baby antenatally diagnosed via intralobar bronchopulmonary sequestration with a mediastinal cyst. He required immediate NICU admission for respiratory distress and was discharged on day 10 of life. He continued to remain on OPD follow-up 6 monthly with a yearly CT pulmonary angio, and was a known case of bronchial asthma for which he was on levosalbutamol and budesonide nebulization. He was posted for elective lobectomy at 3.5 years of life. During pre-operative assessment, the child had an asymmetric crying facies, prominent epicanthal folds, and anomalous right low-set ears. On auscultation, there was decreased air entry on left side, and transthoracic echo showed an ASD. Vitals, general physical examination, blood investigations, and other systemic examination were within normal limits. The CT pulmonary angio revealed air trapping in the posterior basal segment of the left lower lobe, with the focal air-filled cystic area suggestive of mucocele, secondary to segmental bronchial atresia. There was also a well-circumscribed air-filled lesion noted in the subcarinal region. It was decided to manage the subcarinal lesions conservatively with regular follow-up due to its small size, asymptomatic presentation, and inaccessibility by left thoracoscopy. So, preoperatively, the parents were counseled regarding the anesthetic procedure, one lung ventilation, and consent was taken. The perioperative plan was discussed with the surgical team, and a dry run of complete airway planning was done prior to the procedure. Due to the age, weight, and airway anatomy limitations, a special assembly was designed. This included the endotracheal tube with the bronchial blocker and the fiber optic bronchoscope. Normally, during intraluminal insertion, the endotracheal tube is inserted, followed by the fiber optic bronchoscope, after which the bronchial blocker is inserted under fiber optic guidance. Ventilation is done via the port shown by the arrow to avoid desaturation during this airway maneuvering. The ratio between the outer diameter of the fiber optic bronchoscope and the inner diameter of the endotracheal tube should be less than 0.7 to allow ventilation during bronchoscopy. With our airway equipment, this ratio came out to be approximately 0.85. So the assembly would physically fit inside the endotracheal tube, but no adequate ventilation would occur. Furthermore, their maneuverability would be hampered due to increased friction between the equipment. Thus, we came up with a combo approach, wherein the entire assembly was preloaded onto the endotracheal tube. This was done to shorten intubation time and minimize airway manipulation in an already asthmatic child. Let's take a closer look at our assembly with the fiber optic bronchoscope and the bronchial blocker. Pre this modification, we could quickly shortening the intubation time length. We shortened the endotracheal tube so that the fiber optic could reach up to the carina. This also solved the apprehension that the subcarinal cyst would not get ruptured with the tip of the endotracheal tube, just in case it goes beyond the carina. This enhanced our procedural safety. So on the day of surgery, after pre-medication, the patient was induced, ventilated for 3 minutes, and laryngoscopy done. The whole assembly, that is the endotracheal tube with the fiber optic and blocker placed within it, but just beyond its tip, was advanced past the vocal cords and further till the carina was visualized under umbuscope guidance. The blocker was then directed in the left mainstem bronchus and balloon placement confirmed by conventional auscultation methods. Saturation levels remained between 99 to 100% throughout airway maneuvering with stable hemodynamics. Post-intubation, EtCO2 was also normal, that is, there was no hypercarbia. Here, you can see the blocker in the mainstem bronchus and the entire assembly from the outside on the right. So this is an intraluminal method of placement of the bronchial blocker. After insertion of the first robotic port by open technique, the left lung was completely collapsed with adequate intrathoracic space for manipulation of robotic instrument. left lower lobectomy was completed uneventfully, and after completion, the blocker balloon was deflated and the lungs manually ventilated to check for leaks. The left upper lobe was seen to re-expand after completion of the procedure. The trachea was then extubated. The child was discharged from the post-anesthesia care unit on day 3 and discharged from the hospital on post-op day 5. We have also recently published this as a case report. In our next case, the technique of achieving one lung ventilation was via extraluminal insertion of the bronchial blocker. This was an 18-month-old male who was an antenatally diagnosed case of bronchogenic cyst. He had history of recurrent lower respiratory tract infections since birth, requiring multiple hospital admissions. His last lower respiratory tract infection was 20 days prior to being posted for the elective robotic-assisted bronchogenic cyst excision on 22nd November 2025. During preoperative assessment, the child was playful and active. On auscultation, there was decreased air entry on the left side. Other systemic examination and blood investigations were within normal limits, and the chest X-ray depicted left-sided hyperinflation, right mediastinal shift, and a left mediastinal opacity. The CT thorax reported a peripherally enhancing large cystic lesion in the mediastinum, closely abutting the mid-esophagus medially and extending inferiorly into the subcarinal region, producing significant compression of the carina. It was closely abutting and markedly compressing the left mainstem bronchus, along with mild hyperinflation and hyperlucency of the left lung. Superiorly, the lesion was in close relation to the aortic arch, while posteriorly it lay adjacent to the descending thoracic aorta. The right lung field was normal. Given the small airway size, age of the child, and lack of working space in the trachea for an endotracheal tube allowing maneuverability of both the bronchial blocker and the bronchoscope, we opted for an extraluminal bronchial blocker insertion technique. So, after pre-medication, the child was induced and ventilated for 3 minutes. Laryngoscopy was done and a 5 French bronchial blocker inserted. Following this, we inserted the endotracheal tube, followed by the 2.7 French bronchoscope. But it was noted that the bronchial blocker was in the right bronchus. So, we manipulated and inserted the blocker into the left bronchus under ambuscope guidance and fixed at 17 centimeters. This could be due to the obliterated left bronchus compressed by the cyst. So, external manipulation was done and the bronchial blocker guided into the left bronchus. The balloon was then inflated, and the blocker position confirmed and child placed in lateral decubitus position. In our case, fixation of the bronchial blocker was challenging since the margin of error was very less. The blocker was repeatedly getting dislodged with position change and had to be repositioned with the ambuscope. So after repositioning, both the lungs were deflated, the blocker inflated, and the other lung re-inflated, and thoracoscopy revealed a collapsed lung. The surgical duration was 90 minutes. A serratus anterior plane block was administered for postoperative pain for under ultrasound guidance, after which the trachea was extubated. This is a video of the child on post-op day 1. He was discharged on post-op day 3. So we are evolving with minimally invasive thoracoscopic surgeries. Robotic-assisted thoracoscopic surgeries have always been challenging in pediatric patients. There are multiple limitations to robotic surgeries, such as inability to approach the patient due to the robot. Our techniques are also evolving for lung separation, but we have limited gadgetry due to the size of the airway. There are unique challenges and anesthetic implications in each case, requiring a tailor-made approach. Integrating anatomical knowledge, sizing, innovation, and modification of available equipment can help provide a safe approach to one-lung ventilation. So to conclude, the challenges in pediatric anesthesia stem from immature physiology, unpredictable airways, hemodynamic instability from even minimal blood loss, and a narrow margin for error in drug dosing. Diverse high-risk pediatric cases showcased here have critical perioperative challenges. In our cases, individualized anesthetic planning and timely ICU support were key. Multidisciplinary communication improved both intra and postoperative stability, and ICU OT integration enabled early recognition of deterioration and provided smoother postoperative transitions.
Thank you, Anshika.